Today we'll be talking about antiplatelet use. Now, whenever we talk about antiplatelet, we are talking about Ecosprin, Clopidogrel, Ticagrelor, or Prasugrel. So this can be used separately or in combination. We'll be seeing the uses. Now, why we use this antiplatelet is to prevent the intravascular thrombosis and embolization. We must know a very simple fact that the most important factor why thrombosis or clots don't occur is the smoothness of this endothelium. So this is basically blood vessel, and this as till the time this endothelium is preserved, till the time there is no injury, the chances of clotting is extremely less. Whenever there is injury to this endothelium, it will release so many chemicals like thromboxane A2, endothelin, prostaglandin, serotonin. So all these things will cause vasoconstriction, which is the earliest response to any endothelial injury. And after vasoconstriction, these so many chemicals which are released, like von Willebrand factor, thromboxane, endothelins, then they will attract the platelets which are circulating in the blood. So platelets are very small in size, and they keep on traveling the blood vessel. So whenever there is injury, these chemicals will simply attract these platelets. The platelet will go and will bind, and it gets deformed, and it will attract more and more platelets. This is how the clot is propagated. So these medicines, these are antiplatelets, actually act on these platelets to prevent the formation of clot and progression of clot as well. Now, these antiplatelets have three main indications: the cardiac indications, neurological indications, and other. First is the coronary artery disease. Regarding cardiac, we'll be talking about coronary artery disease. Coronary artery disease means the patient who has reduced ejection fraction, or those patients who have normal ejection fraction, but on CAG, on coronary angiography, some artery like RCA or LCX or LAD is showing block, and that block is more than 70%, 80%, 90%. And that patient who has either TMT positivity, or that patient who had heart attack. So coronary artery disease can be with MI, after MI, or without any MI. That can be detected on routine coronary angiography after maybe having the TMT positivity. So in all these patients, aspirin is compulsorily given from 75 to 150 milligram per day to all the patients who have coronary artery disease. But you must know that the primary prevention of ischemia with aspiration is not of any proven benefit. Means anyone has hypertension or anyone has diabetes mellitus, but the coronary angiography is not done, or the patient doesn't have any symptoms, or the TMT is negative. In those patients, the giving ecosprin, giving aspirin to those stable patients without any symptoms, without positive TMTT, without any abnormal coronary angiography, is not of any proven benefit. Now, for coronary artery disease, antiplatelets, those patients who have blockage, they have shown to reduce the fatal and non-fatal heart attack. And in heart attack patients or MI patients, it has shown to prevent the infarction, and it has shown to reduce the mortality. So the next indication is acute coronary syndrome. Whenever we label acute coronary syndrome, it is simply any chest pain patient presenting to the casualty department with active chest pain. That time we label it as acute coronary syndrome. Now, it can be either one of the three. It can be ST elevation MI, or non-ST elevation MI, or unstable angina. It's very easy to diagnose. To call it as ST elevation MI, or to call it as MI, we must have two things out of three things. One, first, the patient must have symptoms, that is either chest pain or chest pain equivalent, like shortness of breath, palpitation, or syncope. These are all chest pain equivalent. So symptom has to be there, or the ECG should definitely show changes of ST elevation or changes of non-ST elevation. Means the patient may not have ST elevation, but patient may have T wave inversion, patient may have ST depression. So ST elevation is not compulsory. And the third thing is positive cardiac biomarkers, which are CKMB, creatine kinase, muscle specific or myocardium specific, troponin I, which comes in the blood early than the troponin T and troponin T. So patient must have either of these three, either two things has to be positive to label it as myocardial infarction. So if there is ST elevation, and then with symptoms it is STEMI. Or if there is ST elevation and the cardiac biomarkers are positive, we can label that it is ST elevation MI. To label it as non-ST elevation MI, patient will definitely not have any ST elevation. But patient may have the chest pain, shortness of breath, or palpitation, or weakness, or syncope as the symptoms. But the cardiac biomarkers are must then to label it as non-ST elevation because there is no ST elevation. That is the reason why it is non-ST elevation MI. And the third thing is that in unstable angina, the biomarkers will be negative. So if the biomarkers are negative, like troponin I, troponin T, or CKMB, and patient has symptom, we label that it as the patient has unstable angina because stable angina usually the symptoms, the features of stable angina are that stable angina, the chest pain lasts for less than 10 minutes. The chest pain improves with rest. The chest pain improves with NTG or the chest pain which improves with the sorbitrate tablet. The chest pain which improves after rest or after sorbitrate, or the pain which is usually less than 10 minutes, we call it as stable. If the pain persists for more than 30 minutes, and if the biomarkers are negative, especially the repeated biomarkers which are sent after 6 to 8 hours of initial biomarkers, if they are still negative, then we label the patient has unstable angina. So for this acute coronary syndrome, whatever it is, like stillation MI or non-stillation MI or unstable angina, we always load the patient with Ecosprin 300 milligram, Clopidogrel 300 milligram. Instead of Clopidogrel, Ticagrelor 180 milligram can also be given. But most of the time, most of the places, Clopidogrel 300 is used, and statin, either 40 milligram of rosuvastatin is used, or either 80 milligram of atorvastatin is used. And as we know, whether it is STEMI, non-STEMI, we always give Clexane or heparin until the patient is hospitalized for maybe around 5 to 7 days. And for ST elevation or not ST elevation, means if the biomarkers are 100% positive or if the SCG shows ST elevation, then the best option is PAMI, that is primary angioplasty for MI or primary coronary intervention, that is PAMI. It is always superior to thrombolysis. And if a thrombolysis is only indicated if the patient has ST MI, if there is non-ST MI, thrombolysis is not at all indicated, but PAMI is definitely indicated. The patency of recanalized coronary artery means if the patient had MI and the stenting is done, then to keep the stent patent, this Ecosprin or Clopidogrel, they have huge role. So patency of recanalized coronary artery or implanted vessel after CEBG is markedly improved by continuing dual antiplatelet therapy at least for 12 months. So two antiplatelet has to be continued at least for 12 months after the bypass or after the stenting or after the PAMI. So next is for neurological, that is ischemic stroke. We don't use antiplatelet for hemorrhagic stroke because it will increase the bleed. But for ischemic stroke, actually they won't alter the course of stroke, but they'll definitely reduce. The Ecosprin will reduce the incidence of TIA, that is transient ischemic attack. Very commonly, patients present with transient loss of consciousness or transient weakness of upper limb, lower limb, or transient neurological deficit, which may improve on its own. So in such instances, continuing at least Ecosprin reduces the chances of transient ischemic attack markedly. And those patients who had recurrent transient ischemic attack, then the chances of stroke is very, very high in those patients. In those patients with TIA, the continuing Ecosprin markedly reduces the risk of stroke in those patients. So, also, the occurrence of stroke is markedly reduced in those patients who have persistent atrial fibrillation and those patients who had previous ischemic stroke. So, at least one antiplatelet, or actually one single antiplatelet, has to be continued for those patients who had TIA, those patients who had earlier ischemic stroke, or those patients who had atrial fibrillation. And either Ecosprin or Clopidogrel can be given to all the patients who had TIA, that is transient ischemic attack. Any patient who has acute ischemic stroke, they are always put on dual antiplatelet, that is Ecosprin plus Clopidogrel for first month, and after 1 month, only one antiplatelet is continued at least for 1 year, which is very, very necessary. The fourth indication where these antiplatelets are excellent or they are very, very important is the prosthetic heart wall. Those patients who undergo wall replacement surgery, prosthetic wall placement, warfarin is definitely given, but along with warfarin, antiplatelet is very, very crucial to reduce the risk of microthrombi and to reduce the risk of embolism. So, this prosthetic after prosthetic wall surgeries, at least Ecosprin is very, very important along with the warfarin to reduce the risk of microthrombi and risk of embolism. Those patients who have arteriovenous fistula, those patients who are on maintenance hemodialysis, antiplatelets prolong the patency of this arteriovenous fistula. So to keep the AVF patent, antiplatelet has to be continued, Ecosprin has to be continued. The last indication which I'll be talking about is peripheral vascular disease. Very commonly, those patients who are heavy smokers, or those patients who are vitamin B12 deficient, vegetarian, those patients who developed intermittent claudication because of the tibial artery or popliteal artery or posterior artery, significant atherosclerosis. Mostly it is always and always because of smoking. In those patients, they get huge pain, especially after doing any physical activity, and the intensity of the pain keep on worsening with physical activities, which we label it as intermittent claudication. This intermittent claudication or significant pain of lower limbs because of the ischemia, because of the atherosclerosis of these lower limb blood vessels or arteries, can be markedly reduced with either one antiplatelet. So giving Ecosprin or Clopidogrel is extremely important to reduce the intermittent claudication pain and to reduce the risk of thromboembolism as well. So these were one of the very important uses of antiplatelets. Thank you.